Welcome, guests. I'm Tarina Scott, president of the Theta Mu Omega Chapter of Alpha Kappa Alpha Sorority Incorporated. And on behalf of the chapter, I'm thrilled to welcome you to the second part of Empower Your Heart Cardiovascular Health Series, hosted by our fabulous health committee. Tonight, we're excited to have with us again Dr. Shanice Gilyard, who shares wisdom, tips, and maybe a few hearts to hearts, pun absolutely intended, about how to keep your heart strong and healthy. After all, your heart does a lot for you, so it deserves more than caffeine and stress in return. This evening promises to be both educational and entertaining because, well, let's face it, learning about heart health and vascular health doesn't have to be cardio boring. So grab your water, get comfy, and let's learn how to love on our bodies a little more without skipping a beat.
Good evening, everyone, and thank you so much for joining us. My name is Katina Jones, and I'm a proud member of Theta Mu Omega Chapter of Alpha Kappa Alpha Sorority Incorporated. Our health committee is passionate about creating spaces like this, where we can have open and honest conversations about the health and wellness of Black women in our community. We know that Black women face unique challenges when it comes to healthcare, whether it's access, treatment, or simply being heard and understood. That's why these kinds of discussions are so important. They give us the chance to learn from trusted experts, share experiences, and remind one another that our health truly matters. Our goal tonight is to educate, empower, and encourage each other to take charge of our well-being, because when Black women thrive, our families and communities thrive too. And now it is my pleasure to turn things over to our chapter vice president, Jasmia Newman, who will introduce our speaker for the evening.
Good evening, everyone. Dr. Shanice Gilyard is an interventional radiology physician at UCLA. She has excelled in clinical medicine, research, and community service. She is a native of Raleigh, North Carolina. Though she hails from the East Coast, Dr. Gilyard now joyfully calls Los Angeles home. As a standout senior in high school, Dr. Gilyard was selected to receive the prestigious Moorhead Cain Scholarship, a full academic scholarship to the University of North Carolina, Chapel Hill. She graduated with distinction, where she received a Bachelor of Science in Public Health with a minor in chemistry. As a supplement to her rigorous scientific coursework, she also studied Mandarin Chinese, French, and later studied medical Spanish. She values being able to connect with a diverse set of people, and her studies took her to Rwanda, South Africa, and Kenya. While in Rwanda, Dr. Gilyard taught English classes to middle school and high school students who were primarily French-speaking. She also taught science classes after her shifts at local hospitals in Rwanda. Upon graduating, Dr. Gilyard matriculated to Case Western Reserve University School of Medicine, where she was awarded the Sacher Pemis Scholarship. She distinguished herself during medical school by completing an exchange research trip to China, where she studied surgery at Beijing University School of Medicine. She later was granted another prestigious award to study transitional research at UT Southwestern on the Sarford Cardiovascular Medicine Fellowship. Throughout her training, she has prioritized serving the greater community. She joyfully co-leads the Community Service Division at the Charles R. Drew Medical Society. Along with Dr. Jessie Stewart, Dr. Gilyard leads the semi-annual trips to Nairobi, Kenya, where she trains residents in minimally invasive surgery. Let's all please welcome Dr. Shanice Gilyard.
Hello, everyone. Thank you. And thank you for joining me again. It's a pleasure to be here. So I think there's a few folks who were with us last time. Actually, I think half of the crew was here last time. And so it's a pleasure to see you all virtually again. Thank you so much for joining us this evening. I know there's a lot to do in LA at night. So thanks for spending time with all of us to learn about your heart. So part 2 of our series. Today, we're going to talk about heart and vascular health. I'm going to try to break down some of the diseases that disproportionately affect our communities with a focus on what things look like in women, because right? We have a group of amazing women here today that are really pushing the boundaries on trying to educate our communities, especially nowadays, because information is becoming harder to come by, especially good quality information. So to recap, we last time reviewed some conditions that increase your risk of having some problems with your heart and your blood vessels. So last time we talked about hyperlipidemia, or the medical term for high cholesterol. And that means your cholesterol is too high. This increases the risk of stroke, heart attack, and peripheral artery disease. We also talked about hypertension, elevated blood pressure in the United States, especially among Black people. This is the #1 cause of stroke. And we talked about diabetes, or as my grandmother calls it, the sugar. And this can cause chronic kidney disease, actually can cause you to have high blood pressure and harden the blood vessels in your body. So, and last time we also talked about ways that you can manage it with diet, exercise, and medication. But this time, now we're going to pivot to, okay, so these are the causes. What are the consequences? So that's step 2. It's not going to be as fun as step 1. So the first thing we're going to talk about is heart failure. A lot of people probably heard the term heart failure, but maybe no one explained exactly what heart failure means. Really, it's kind of a big term for the heart's not pumping as well as it should. So it just, and there's many different degrees and categories of it. And so maybe someone has a family member or neighbor that has something called heart failure. We're going to talk about what that looks like and what you should know, because it often, of course, unfortunately, disproportionately affects us. The next thing we have to talk about is heart attack. Basically, this means that not enough blood is going to the heart because the heart itself is a muscle. And so on this very, very liberally drawn drawing here for the heart, you can see like these little squiggly lines inside. Those are actually blood vessels that feed the heart itself. And when someone's having a heart attack, those blood vessels get cut off, and now they don't have enough blood supply to feed the muscle of the heart so it can do its work. We're going to talk about stroke. Unfortunately, the same process that happens all throughout the body can happen up in the brain because we have blood vessels in our brains. That means not enough blood is getting to the brain. So just like your brain thinks, it also needs blood to do its job. And so when not enough blood is getting there, that can cause a stroke. Now, the kind of stroke depends on which blood vessel in the brain gets cut off. Or there can be blood in the brain or a hemorrhagic stroke, which can damage the brain too. So either of these things can happen as a result of the conditions that we talked about last time. Finally, we're going to talk about vascular disease, a disease that I know extremely well. It is part of, all of these diseases are part of my daily practice, but most of my practice focuses on treating vascular disease, meaning that just like we have arteries in our heart, our brain, we also have arteries and blood vessels in our legs. And sometimes they can get clogged and not enough blood gets to the legs. So we're going to talk about all 4 of these topics in the next hour. It's a lot, but we're going to get to it. So I just kind of was like, wanted to know what's the impact of cardiovascular disease, because a lot, depending on studies you read, they will kind of lump a lot of these diseases together. So the green means not a lot. The yellow means, okay, things are not looking great. Red and orange means we need to do something about it. And of course, the United States, the entirety of the United States, Canada, Alaska falls under the, we need to do something about it. So the prevalence, meaning how many people per 100,000 of a disease in the United States, is very high. And then in parts of the northern part of Africa, it's extremely high, like very, very, very high. And part of that has to do with diet, environmental exposures, and then also the inability or limitations of physicians to treat some of the diseases that are endemic in the region. And so it's kind of an emergency in this region, truly. Okay, I know that everyone's having fun just sitting here listening to me, but it's 7 o'clock and I want everyone to be awake. So we're going to do our first team engagement. So if you're on your phone, you don't have to worry about it, or you can go to polleverywhere.com, /Gilyard or /Gilyard049, and or you can scan this if you're on your laptop, and you can use your phone, and we're going to do our first poll. So I'm just going to activate it. Hopefully we're active. Yes, we're active. And then as the poll answers come in, we're going to look at this. And so I am going to change my screen sharing, and we're going to see how people are doing on our first question. We have 13 surveys underway. We can probably get a few more. All right, 13 is not bad. Okay, so let's see here. All right, what is the leading cause of death in America? Or adult women globally, sorry. Okay, we have cancer, cardiovascular disease, and liver disease. So even though cancer is something we talk about a lot, actually cardiovascular disease is the #1 killer of all women globally, which, if you stop to think about it, we do so many Susan G. Komen walks for women, and we absolutely should. But wow, we might be missing some of the public perspective on cardiovascular disease being our #1 threat, especially because, as a woman prior to becoming a physician, my understanding was that a lot of the stereotype of cardiovascular disease was always a man. And so to see that this is a problem was kind of shocking. So here's one of my big did you knows, and this is something that I didn't know until much later, that women with all the risk factors that we talked about last time, diabetes, smoking, high blood pressure, all have a greater relative risk for cardiovascular disease compared to men with the same risk factors. So what does that mean in plain English? I'm taking some more advanced statistics courses. So relative risk is one of those, it's a number that you can measure comparing two different groups. But what it really means is that if I and a man were the same age, and he smoked and I smoked, I'm more likely to have bad things happen to me than that man is. And it's not fair. Just like men lose weight more easily, it's not fair that certain things have more consequences, right? Like men can literally just drink some water and they'll lose 10 pounds. And I can literally eat only lettuce for 3 months and I will gain 10 pounds. And it is what it is. But now that we know that some of the things that we're told are really dangerous for our bodies, we can now, as women, be empowered to say, okay, we're really going to take control of this, because people do not tell us how dangerous this is, especially compared to the male population. Okay, so the first thing we're going to talk about is heart failure. So what is heart failure? Okay, all right, I have a little video of a cardiac ultrasound we're going to try to play here. Hopefully it plays. Otherwise, it's not that big of a deal. Essentially, heart failure is when the heart's not pumping effectively enough. And so to see heart failure, we're going to have to actually get an ultrasound of the heart and to actually calculate how much blood is being pumped out. So the heart has 4 chambers, and to have heart failure, essentially, it can be on one side of the heart or the other. So it can either be on the left side of the heart or the right side of the heart. Most common is left-sided heart failure. So when people tell you they have the heart failure, 9 times out of 10 is going to be the left side. And what that means is the left side of the heart is supposed to squeeze every time the heart squeezes, it's supposed to squeeze about 55 to 65% of the blood inside out of it. It's not supposed to squeeze 100% because then it wouldn't have any blood left, but it's supposed to squeeze about 55% to 65%. When people have heart failure, that number drops. And so people start having symptoms of heart failure when they hit about 30%. So when people say, oh, they say my heart is at 30%, it's actually not 30% out of 100. 30% ejection fraction, or when people say, oh, they say my heart's at 30%. Yes, we should definitely pray for them. But what that really means is it's working at about 50% of normal, not 30% of normal. Does that kind of make sense to everyone? Yeah. because normal is 55 to 65%. So what are the causes of high heart failure? High blood pressure is number one. It causes stress on the heart. So that left side of the heart has a push against a lot of pressure. And so when it's pushing, the heart is like, please help me lower the blood pressure. And, we have to be really cognizant of that, because that's why in my last talk, I talked about high blood pressure being a silent killer, because you don't feel the blood pressure, but your body does. And so the heart is working really hard against increased pressure. And eventually that muscle can fatigue, and it can cause, basically we see what something called left ventricular hypertrophy. So the muscle of the heart builds up because it's training. It's really pushing against a lot of extra pressure, but it can increase that stress. And sometimes that muscle doesn't get fed enough, and you can actually have heart attacks. So heart attacks are a huge cause of heart failure, because when that not enough blood gets to the heart, that part of the muscle actually dies. And so once that part of the muscle dies, it forms a scar. And when that muscle is a scar, that muscle is not able to squeeze as much as it was before. Other thing I highlighted for women is pregnancy. So every other month, I probably update a list of reasons why pregnancy might kill me. And this is like, laughing, like, oh, this is dangerous. But pregnancy is one of those things that a lot of women don't know about. We know about, like, maybe a lot of people have heard of preeclampsia. You can give me a hand raise if you've heard about something of preeclampsia or eclampsia, but I don't know if anyone's ever told you all that heart failure can actually happen as a result of pregnancy. So there's something called postpartum cardiomyopathy, where like a small percentage of women will develop heart problems after giving birth. And so we think sometimes, like with the volume of blood that has to go through the body with the baby, the heart is not able to pump and keep up with that volume, and the person develops cardiomyopathy. Some women can also having preeclampsia and eclampsia is shown in studies to increase your risk of heart disease. And it also doubles your risk of having high blood pressure in the future. So we don't understand eclampsia. We understand how it happens, but we don't understand why it happens. And because we don't understand exactly why it happens, we aren't able to say exactly why it causes higher risk of disease later in life. But my suspicion is that there's something going on in the blood vessels that you don't know about, and it manifests later in life. Does cardiomyopathy reverse after birth like preeclampsia? That is an amazing question. Not usually. And so women who have postpartum cardiomyopathy, sometimes you can recover some heart function, but the women that have very severe cardiomyopathy may end up needing heart transplants. Ooh, that's so good. How can we better support women in protecting their heart health before, during, and after pregnancy? So I always encourage women to do like preconception counseling. So with your physician or an obstetrician, it's really important, especially for Black women. When I was in college, I was part of a preconception health planning team, especially working in Black communities, to talk about like the vitamins that you're going to need to be taking, like folate and all of the rest of your vitamins, and preparing your body for pregnancy. During pregnancy, I think what we really need to do is a better job of telling women what to look out for during their pregnancies. And so one of my heroes, who's been very outspoken about her pregnancy, is Allison Felix. She's, I think, is a member of Your Lady Sorority. And she, during her first pregnancy, like we actually spoke a little bit about this, she had actually high blood pressure. She had eclampsia and was extremely sick. And she was sitting, I think, at like around Thanksgiving time, and she said that her legs swole up, like unbelievably, extremely swollen. And, she wasn't feeling well, but she was kind of okay. And then it turned up to be something very serious. So educating women about what it looks like when pregnancy is not going well needs to be very widespread. And, we were all shocked, in those of us who follow track and field closely, by another runner who was an Olympian, was found actually dead in her home about a year ago, while she was at like month 7 of her pregnancy. And we don't know for sure what happened, but it may have been an eclamptic seizure. And so knowing what things look like before they get really bad is something that's really important to empower. And then afterwards, having regular checkups. What I've noticed about a lot of my patients that are moms is that early newborn phase is so busy. It's like, so, and it's very hard to take care of yourself while you're taking care of another human. And so having familial support, spousal support is going to be so important, so that you can, you take the baby to these newborn visits like almost every 2 weeks. But after you have a baby, your OB-GYN is like, all right, see you next time. There's a person living in there. And so, and for women in like reproductive years, our doctors are usually our OB-GYNs. So making sure you have a primary care doctor to follow up on these things is really important. Wow. Yeah, I lost her baby to high blood pressure. And so it was, back then they probably didn't call it eclampsia, but that's probably what it was, sharing. Another thing that women experience, unfortunately, slightly more than men, is depression. And shockingly, I guess people say things are matters of the heart when they're emotional, but depression also can be an independent risk factor for heart disease in women. And I was a little bit surprised by this because, I talk a lot about like the diseases and stuff I can fix. And I can't fix depression. I'm not, a psychologist so broken heart syndrome, I didn't get a chance to talk about that one, but broken heart syndrome is, yes, like emotions and our stress can affect our heart, but broken heart syndrome actually is something that can send people into heart failure. It's called Takotsubo's myocarditis. It's very rare, but in cases of extreme depression, it can actually cause the heart to not contract properly. And it's very rare, but it's like people who have like an acute traumatic broken heart that can happen. So in addition to taking care of our bodies, we need to take care of our minds and our spiritual selves too, so that we can be healthy, because even though some people are quick to dismiss the mental health, our mental health can affect our physical health very dramatically. Okay, so what are signs of heart failure? I had a friend not too long ago call me over and say, hey, doc, I noticed like my friends call me Shanice, but when something's wrong, somehow it's, hey, doc. So my friends goes, hey, doc, how are you doing? Okay, what's going on? I'm not feeling so good. I've had this cough for about a month, and I'm like really tired, and I feel a little short of breath. And you know what? My legs were swelling. And I said, if you don't go to the hospital, do you have a history of heart failure? Well, no, but I've been working on my blood pressure. And I said, okay, I need you to go to the hospital. Of course, this person waited a couple days, but made it to the hospital and was in an acute basically heart failure episode. And by the time they got out of the hospital, they had lost 15 pounds of water weight. And so this was a new diagnosis, even though probably had it for a while, and something tipped them over the edge. So what are we looking for? So swelling of the legs. Usually your doctor will say, oh, if one of your legs is swelling, worry about a blood clot in the vein. That is true. If both of the legs are swelling, that means the pump is overloaded and stuff is backing up, just like a sewer that's clogged. Think about it like that. The highway, there's a crash on the 405 and traffic is backing up back there, and that's the fluid. And so both of the legs are usually extremely swollen. People also experience shortness of breath because, again, that fluid is not getting out of the lungs too. So the blood vessels in the lungs are like drowning. They're like, help, please, make me dry. And they're struggling. Needing to sleep on multiple pillows to breathe. I'm not saying like if your neck hurts and you need more pillows. This is a specific sign for heart failure. It's something called orthopnea. It's a very fancy medical word, but it basically means that when you're laying down, there's too much fluid and pressure. So when you sit up, the air exchange can happen at the top of the lungs. And so people subtly don't realize like, I don't feel so good. You know what? Let me just get another pillow. And they don't think about that. But that's something that if you or somebody you know and love is, you go into your auntie's room and check on her. Hey, auntie, so and so, how are you doing? And you see 5 pillows on their bed. And you're like, why are you sleeping on 5 pillows? Does your doctor know you're sleeping on 5 pillows? And you go, yeah, it's just more comfortable. It feels better to breathe. That's something that you need to look out for heart failure. Another thing is trouble walking distances that used to be easy. Now we all get a little older and, maybe get a little arthritis. I was running, sprained my ankle. I can't walk the distances that used to be easy a week ago. But in general, if you feel like notice or someone you care about is walking and they're walking a lot slower and it seems to be more winded, they need to see a doctor because there might be heart failure. A new cough that won't go away is something that people miss. So, oh yes, I'm getting to that, Katina. The new cough that won't go away. One of my aunts, honestly, had a cough that wouldn't go away for a year. And she was like, it's not COVID. It's not the flu. Her doctor said, oh, well, didn't you have asthma as a child? It's probably asthma. It was not asthma. It was heart failure. And so that, after all the things are negative, we need to look. And then heart beating really fast is non-specific. But sometimes when the heart can't pump effectively, it has to beat very fast so that it can get the same amount of blood out. Exactly. So what do you do if you have your symptoms? You're going to call your doctor. If you're having trouble breathing, we're going to the hospital, okay? We're going to the hospital. Now, what tests should they run? That is exactly what you should ask for. So the first thing we're going to ask for is an EKG. Now, it stands for an electrocardiogram, but we borrowed it from the German, so it's still holdover from that, EKG. This is a normal one. You're going to have this little thing called a P wave, and then a QRS complex, and then a down, and then a T wave. This is a beautiful normal EKG. The reason that they do this is because one of the causes of a heart not working properly is a heart attack. So they want to know if you have a heart attack or have had a heart attack, you can sometimes see changes on this. But this alone will not diagnose heart failure. So if someone says they did the little beep, beep, boop machine on me and they said my heart was fine, I don't have heart failure, that is not true. The gold standard test to see if someone has a heart that is pumping effectively is an echocardiogram. So it's an ultrasound of the heart in multiple views. And it basically, you see this kind of color thing here, that looks at multiple things. So it looks at the heart valves, so the difference between the chambers. And it also looks at what percentage of the blood gets squeezed out of the heart every time. So unless someone says they did an ultrasound of my heart, they can't say for sure that there's no heart failure. If they just do this, that's not going to tell you. So some people with heart failure have completely normal EKGs. And that's the EKG really just looks for electrical problems with the heart, and a heart attack can show up as an electrical problem. Now, if someone has heart failure, we're going to look at something called I encourage my patients and my friends to say, can I get a cardiac MRI? And why is that? It's a very specialized test, but especially for us as African Americans, it can look for things in the heart that may not show up on other tests. So if they say, oh, you didn't have a heart attack and you didn't have some of the other stuff, we don't know exactly why your heart's not pumping effectively. We need to have a cardiac MRI. And that can look at the structure of the heart. It can look for prior heart attacks, and it can also look for different deposits in the heart. So does everybody, hopefully I'm not aging myself here by saying, do you all remember the great and late comedian Bernie Mac? Yes, so Bernie Mac had something called sarcoidosis. And sarcoidosis can affect all the parts of the body. It can also affect the heart, but diseases in that spectrum can affect the heart muscle. And unfortunately, Black people, hello, we get those more often too. Don't know why. But an MRI is going to be the gold standard test to look for the things that can affect that. Okay. This is a lot of information. I am not going to make you go through this. This is what I make my medical students tell me when I'm bored and I want them to give me information to entertain me, for their own learning, I promise. But if someone has heart failure, it is classified based on how they are doing. So someone who has a heart that's pumping at 30%, but they're able to do everything, ordinary physical activity, they don't get tired, they don't have, their heart doesn't start beating fast, they're still going to be in a lower class of heart failure than someone who can't breathe when they're laying down. And so someone can't do any activities or struggle with showering, taking like sheets off a bed, cleaning windows, playing golf, or just walking, then we're looking at different classes. So this is like the New York Heart Association NYHA classification. Okay, any more questions before I move on to our next disease, which is a heart attack? Yes, I just see tech there, so I don't know.
I have a question.
Yes.
So, I like how you told us the different things to ask for.
Mhm.
I found that last one, well, even to get an appointment with it, like I was having like heart flutters, and in my mind, I was dying today. And
You
when
know,
I called
yeah.
the nurse, they were like, "Oh, a doctor can't see you for a month." And I was like, "Well, what happens if my heart stops?" She was like, "Go to the emergency room." Like, so I wanted to know, what do you feel, or what are your thoughts on, because all these things are popping up where you can like go get scans, or you can go to like Turkey and get all these medical procedures done. Like, if I came to you with my results from Turkey, like, would you accept that, or should a doctor accept that from somewhere else, since it's so hard to see doctors these days?
Okay, that's a good question. So first part is going to be, if you're feeling like your heart is fluttering really fast, that is an emergency room situation. Unless, okay, I'm one of those people where I'm like, am I passing out? No, okay, I'm alive. That's fine. I'm not going to the emergency room, because my worst fear is my colleagues having to take my clothes off. Like, that is like my worst. Okay, like I have a lot of irrational fears, but that's one's really irrational. Okay, like I drive with my seatbelt 10 and 2. I'm like, no, y'all are not about to do this to me. But so you're right. Getting testing, especially if you're not having an emergency, is increasingly difficult. And right now, especially with our political situation, it is anticipated to get a little bit worse. Oh, yeah, Sherry. I'm going to respond to that in a moment. But if you have results, so say you're having like back pain or something like that, and it's taking 3 months to get an MRI, or they're like, you need a referral to this and that, and you're able to get an MRI on a 1.5 or 3 Tesla magnet, and you send me your CD, I'm going to look at the results. Now, the problem is with these full body testing things that they advertise, a lot of times it's on a low magnet, and like, especially these full body MRIs, to do an MRI properly of just like one part of your body actually takes quite a long time. And so these full body MRIs are probably not very specific for certain diseases. So like, it would be, I mean, they could see, like, for example, a big cancer, but they're not going to see like any problems with the heart, because that requires something called gating, where you time the MRI with the beating of the heart, and then you go back and reconstruct the images, so you have an image that's still, as opposed to a moving image where it's like blurry. If you've ever tried to take a picture of something moving, you're like, okay. But if you get tests somewhere else, no, I think most physicians at this point, as long as you can get the test and it's a decent quality exam, will take it. Okay, so ejection fraction is, someone made a comment, a very thoughtful comment about a patient that had a 20% ejection fraction, meaning that their heart is basically working at a third of normal. So it's really not doing well. Had a lot of anxiety. And that's very common, unfortunately. We know that when patients have heart trouble, they get very anxious. Also, the heart rate can go up when the heart's in trouble. Ejection fraction is the percent of blood, is the percent of blood that the heart squeezes out. And so that basically is that 55 to 65% normal is normal or normalish. Yeah. So when someone's at 20%, you're like, okay, you're working at a third. Okay, so we're gonna move on to heart attack, myocardial infarction. That means that the blood of the heart wall has stopped going there and it causes part of the muscle to die. And I like went back and forth about, should I put die in there? It's really strong word, but that's really what happens. Just like when you know, and then you form a scar. So the proper muscle just withers away, and then in its place is a scar, and that scar does not function like normal muscle. I put some information here that was really upsetting to me. So the prevalence of a heart attack is higher in Black women than all other racial and ethnic groups of women. Again, like, and then Black women also have a higher incidence of sudden cardiac death as the first manifestation of like acute, basically coronary heart disease than white women. So what does that mean? Like white women somehow make it to the hospital and they are like, you're having a heart attack, because they're believed in our medical system than Black women. Black women might come to the hospital and say like, I'm having some symptoms, and they don't get worked up for a heart attack. And so when they find out they have a heart attack, it's unfortunately the big one. It's more commonly to be the big one. And the worst part is their survival rate out of hospital arrest is 1/3 of whites. And now, what can we do to fix this statistic? We can all do a BLS course. So we can all learn how to do cardiopulmonary resuscitation, because you have a much higher rate of surviving a heart attack, or you or someone you love have a higher rate of surviving a heart attack if someone, a bystander, can give you CPR in that instance. So just food for thought. I first got my CPR certification when I was like 10. All right, so we're gonna go back to our poll. So make sure no one's taking a nap right now. And then I'm going to change my screen to here. All right. So, all right, we've got some surveys coming in. 10 are underway. Hopefully. All right. So thank you all for doing my word cloud. So I'm very impressed by you all's knowledge. I'm very proud of you all for knowing this information. So I asked for you all to name some signs of a heart attack in women, because it can be a little different than men. So we have shortness of breath, anxiety, left arm pain, so true, tingling in the hands, shoulder, back, jaw, difficulty, like basically pain, chest pain, breath pressure, headache, signs, swelling, pains, and feeling weighed down. And I guess I can go. I mean, I'm already home, but I guess I can go home now, because you all did such a good job answering these questions that we don't need to answer anything else. But you all are very, very correct. So women, of course, because we're understudied in science, and Black women are terribly understudied in science and medicine, let me try to share the screen. Is it sharing my slides again, or is it back on sorry?
We still see the words.
Okay, great. All right, I'm gonna switch over to the slides again. Thank you. All right, well, I'm gonna just stop share for just a second, and then I'm gonna redo that. Goodness. All right, sorry, having some technical small thing. All right, we're gonna exit there. All right, we're good. And all right, great. Everyone can see my screen now? Okay, so you all did really well with that word cloud. And You're right. So sudden chest pain is still the most common sign of a heart attack. Like I've talked to patients who've had it and they're like, it felt like I was being stabbed, like a crushing chest pain. But pain radiating to the back of the jaw, and that kind of ankle, the neck, and the shoulder pain, arm and back can be more common in women. Okay. So, and it won't be just like an ache. It should be a, wow, this feels like a lightning bolt, like very uncomfortable. Sudden pain in any of these areas, plus really just getting sweaty and nauseous all of a sudden, that can also be a sign of a heart attack. And then sudden pain or sweating and nausea out of nowhere with like just being like, oh my gosh, I am just tired and short of breath. And then just a panic, a impending sense of panic and doom is also a sign. And the panic is coming from the fact that the heart is beating extremely fast because it's asking for help. And that also can be a sign of a heart attack. So what causes heart attacks? The primary cause of heart attacks is going to be plaque rupture. So what does that mean in like normal terms? So basically, like we talked about, arteries can get sticky and they get all this plaque and it builds up and it breaks, and one of these breaks off and then goes south and it blocks a smaller vessel. So that's usually what happens. Sometimes we can have spasms in the blood vessels, and that happens actually more commonly when people are smoking. There's also something called a spontaneous artery dissection. So that can happen in women. It's again, very, very rare, but when it happens, it's most often happen in women. And so that is just like, you're minding your business, you're drinking your water, and that artery can just split a little bit. Oh no. Sorry. And that presents with extreme crushing chest pain. Like that is a very acute, sudden chest pain that can happen. So diagnosing heart attacks. Oh, okay. I'm gonna go to Shelly's question in just a minute. Is that EKG? So this one looks a lot angrier than the one I showed you. You see like these kind of angry bird brows there. They look really, really stressed out. This is called an ST elevation. So in medical terms, that's a STEMI. That is an emergency. This is an emergency, and to treat it, you're going to need a cardiac catheterization, meaning someone will go into the blood vessel into the heart and get to the cath lab. So someone asked them 2 questions. How do I feel about hands-only CPR? It is still effective because you're still recirculating. It is less effective than, partnered CPR where someone's giving breaths and compressions, but it still can save lives if you get to it quickly and you engage EMS. If I'm alone and start experiencing signs of a heart attack, you need to, honestly, if you can, share your location. All of us have like advanced phones. I would send an emergency alert to a family member and friend and call 911. So get multiple people, multiple eyes on you. Make sure your emergency contacts are updated. We have this 90-minute rule. 90 minutes, door to catheterization in 90 minutes. So if someone's having a heart attack, by the time they show up, the hospitals figure out they have a heart attack, they should have called an interventional cardiologist to come in there and open that heart attack up. Okay. And because I live in Los Angeles, I was like, if I'm having a heart attack, where do I need to go? And I figured you all would want to know too. Every hospital cannot do this, okay? I'm gonna repeat myself. Every hospital in Los Angeles, there's hundreds of them, cannot do this. So if you're like, where are the hospitals that can treat this? I have an auntie I'm worried about. She don't take her meds. Like I have an uncle that smokes every day and he doesn't take his meds, and they're trying to send them to XY hospital. No, these are the only ST elevation myocardial infarction approved receiving centers within Los Angeles as of June 2024. I haven't seen them updated. So it's actually a small list of hospitals. Within Los Angeles proper, we have Cedars, we have UCLA, and Harbor is like down in Torrance. And then we've got West Valley as a STEMI center. They do have a cath lab, and then Santa Monica. And so Providence is there too, but they're not a lot. So, I encourage everyone who has any kind of loved one that has any risk factors to just kind of go onto Los Angeles County website, take a look at this, and just kind of have an idea of where to go in case of an emergency. What if I have Kaiser? Good question. So some of the Kaisers do have these facilities, I think but it's only Kaiser Sunset. Now, if you have Kaiser, they have a sharing agreement for their emergency situations. So your ambulance would take you to the nearest STEMI hospital. So you have to tell the ambulance, I think I'm having a heart attack, I'm not feeling well, because that way they triage you to the appropriate hospital. Kaiser will have to basically pay that hospital to take care of you until you're stable enough to get transferred to a Kaiser facility. So that's kind of how the Kaisers work. Okay, other tests. So what if I have symptoms? The ED does this little beep, beep, boop machine that goes deep, 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 and I don't have a heart attack, but I'm still not feeling great. And I get a little short of breath when I'm walking. I'm having some chest pain that comes and goes. The first thing they're going to do is a stress test. So they're going to stress your heart out in a controlled way to see if it causes any changes on your EKG. So maybe they didn't pick it up while you were laying down in a hospital bed, but maybe it happens when you're running. They're going to try to stress it out. Another test they can do is a coronary calcium CT. This is one of my specialties, and it's a way to see if there's plaque buildup in the heart vessels, and there's a calcium score. So if you have any of the risk factors that we talked about, high cholesterol, diabetes, a 20-pack-year history of smoking, even if you're not a current smoker, you can probably talk to your primary care doctor and say, am I eligible for a coronary calcium CT? It's a low-dose CT scan. It takes about 30 seconds, and you'll get a coronary risk calculation that will show what your risk score is for having a heart attack, because we've done thousands and thousands and thousands of these nationwide. We've compiled the data, and we can see if the main heart artery in the heart is at 90% blockage, and you need to go down a path of working things up. I will give you all one little secret. So at Emory, I used to also read the executive kind of things where like very big companies would send people in for just routine tests, just out of an abundance of caution. Coronary calcium CTs were one of the most prominent things we did. And so a lot of even healthy people can get them. It's just, you have to know to ask. The other thing is the cardiac catheterization. So if you're having chest pain, all these other tests are not completely sure. They might do a procedure just to see if there's some blockage that they need to treat. But if you're having chest pain and it won't go away, or you're having intermittent chest pain with exercise or anything else, make sure there's an answer. And sometimes it's really, doctors might not be the best listeners. And so you need to just advocate for yourself and ask for these things on behalf of yourself or someone you love. Okay, really quickly, we're going to run over risk factors. So one of the big risks is, of course, high cholesterol. It increases the plaque, it builds it up in the blood vessel, and then it ruptures. Diabetes increases your heart attack risk by 3 times. So a person with diabetes has 3 times more heart attack risk than someone who does not. Smoking, though, can increase the heart attack risk in women 7-fold. So like I said, women, we just bear more consequences, and this is manifest. So I put a little vape in there too, because the data isn't out long enough for vapes to see if this will happen, because the generation that's vaping hasn't thankfully vaped long enough for us to see them have heart attacks. They've had lung issues, but I suspect that their risk will also be 7-fold higher. And then high blood pressure. And we also know smoking causes high blood pressure. So when someone has a high blood pressure for a long time, for years, and their blood pressure is always, the top number is over 180 when it's supposed to be 120, it increases the heart attack risk by 3 times. So how do we prevent it? Because we're all about prevention. Lower your cholesterol. So we're going to decrease the fats in our diet. We're going to check our cholesterol, and we're going to treat the cholesterol. So if all of the stuff that we've done to lower it holistically matter, but don't work, we're going to go onto medications. And we're not going to be afraid, because we know that treating this will lower my heart attack risk by 3 times. Control our blood sugar.
So check our hemoglobin A1C to reduce our blood sugar, okay? And then we're going to stop smoking. We are going to stop smoking. That is it. We're stopping smoking. We're going to do whatever it takes to get there. And then keep that blood pressure nice and low. We have a comment that said, I know a girl who had a heart scare in her late 20s after vaping for years. She passed out and ended up in the hospital to recover. Yeah. And because, you know, what may have happened is that coronary artery spasm, where it literally causes the blood vessel to just close off from like a muscle, basically a muscle cramp, just like we have a Charlie horse, and your Charlie horse is in your blood vessels. That could have been triggered by the vape. And so those, you know, they're very dangerous. All right, friends, we're going to do our next and second to last team engagement session. I'm going to activate our poll. Is it? And into it. All right. All right. So what are signs of a stroke? Oh my gosh, I'm so proud of your all's word cloud. All right. So can you all see the word cloud? Nod. Yes. Tech support. All right. Thank you. All right. So we have dismemberment, facial changes, droopy, face. Yes. Vision, body. You're unable to speak. Yes. Both arms, numbness, slurred speech. Yes. Numbness, lightness, headache. Unfortunately, headache is like can happen, but it's pretty rare with strokes. So we're going to look at strokes because unfortunately, we also get those more disproportionately. So to stop here real quick. Okay. My desktop is having a moment, but so screen sharing failed to start. Try again later. That's exciting. All right, can you all see my screen? Great. Okay, so this is like the acronym for strokes. Like put it on your wall, imprint it on the brain in case you know someone and like or you know anybody. We say be fast. This is the Cleveland Clinic's graphic. I think is great because it used to just be fast. So be fast. Balance, B, balance. Loss of balance or coordination is a sign of a stroke. It's a sign of a cerebellar stroke, but it is a sign of a stroke. Changes in the vision, acute changes in the vision. Like my eyes are getting worse as I get older. It's a gradual process, but I don't think it's not that in itself isn't a sign of stroke. It's, oh, wow, I think I'm seeing double. That can be an ocular stroke, okay? Drooping. Facial drooping is very important, but honestly, it's drooping on one side of the face. And why is that? Because our brain has duplicate vessels and they go to different sides of the brain. So actually, when you're having a right-sided stroke, that means the blood vessel on the left side actually is closed off usually. Arms and legs. Now, if someone's weak in both their arms and legs, I still want them checked out for a stroke, but most commonly it's going to be the one side of the face and then the opposite side of the body. So they're going to be weak on arm and leg, but it'll be the same side, arm and leg. Speech, difficulty speaking or understanding others. The understanding part is really important because that can be a sign of like a stroke and aphasia is someone who was very cogent yesterday, not being able to understand what you're saying when you're speaking very plain language to them can be a sign of a stroke. And T, time. We have to call 911 and engage our emergency services very quickly. How do they diagnose? Again, just like we need to go to heart centers when we're having a heart attack, we really need to go to stroke centers when we're having a stroke. So the first thing that we're going to do is we're going to get a CAT scan or CT scan of the brain. A CT scan does not rule out a stroke, but it does check for bleeding and swelling, and it can show if a blood vessel is clogged in the brain. Some metropolitan areas have stroke mobiles. So if 911 is called and it's a code stroke, they will get a brain CT in the ambulance because these ambulances are equipped with CTs. And I will have read it and engaged the stroke team immediately. So when I was at Grady Memorial Hospital in Atlanta, Georgia,
we had mobile stroke units. And so the CTs would be coming in from the mobile stroke units. I would be reading out the CT and saying, okay, there's no bleed, blah, blah, blah. If there's no acute blood on there, they're taking you up to the cath lab immediately, and they're taking the stroke out of your brain. And so that like has sped up a lot of the stroke care in that metropolitan area. The other thing we're going to get, if this is negative, but there might be a blood vessel clog, they might immediately take someone to a cerebral angiogram, which is just like a cardiac cath, but we go in through the artery in the leg and then basically pull out a clot. This person has leukemia in here. But we're gonna pull out the clot, okay? And that is one of the newer technologies, because honestly, the technology just didn't exist 40 years ago to be able to do that. Now the catheters are microscopic, honestly. They're smaller than the inside of a pen tip, and it can stroke out, like it can pull out the smallest amount of clot. The other big thing we're gonna do is an MRI. And an MRI is important because if the CT doesn't show anything, an MRI can show old strokes, okay? A CT will show very old strokes, but an MRI will show a stroke that happened maybe 3 days ago. And it can show the small strokes that won't really be perceptible on a CT scan. I have a big yellow clock here because stroke time is brain. So classically, we say our stroke window is 4.5 to 6 hours. Newer technology has extended the period of time in which doctors are willing to treat strokes at specialized centers. But for like most of our hospitals, for treating strokes, we're going to probably want to know the last time someone was normal. So they say, oh, like, when was the last time Uncle Bob was normal? And you say, oh, I think it was yesterday. They're going to be very worried about treating the stroke with a clot buster medication, because once you're out of, honestly, I say now like it's 12 to 24 hours, but I still put up the classical thing just to prepare you all so you know how important time is. They are going to not give the clot buster because it increases the risk of bleeding so badly and so high that the risk of bleeding is not worth treating the stroke. They're just going to manage the symptoms of a stroke. And again, we can go onto our LA County website and find all of the stroke centers in Los Angeles County. And look, there's a bunch in Kaiser. Isn't that nice? Okay, so Kaiser Foundation Hospital has quite a few registered stroke centers, PIH and other things like that. So again, just knowing, having a general idea of, okay, what's the closest hospital to me that can do the right things in case of an emergency is good to have in mind in case of an emergency. Okay, we're in the sake of time, we're going to not do our last engagement question, but I want to talk about risk factors for stroke. So again, high cholesterol. I have said this so many times because cholesterol is terrible. Diabetes increases the risk of plaque buildup and inflammation, also in the brain. Smoking, it will double the risk of the stroke and adds on to any other risk factor. So if someone has smoking and diabetes, just go ahead and add up those numbers. High blood pressure increases the stress on blood vessels. Women over 70 with a blood pressure, like the top number over 160, have a 7% chance of developing a stroke. Not compared to other cells, not 7% more. They have a 7 out of 100%. So when I'm telling patients, I really need your blood pressure down, and they're like, well, doc, I don't feel anything. You're just trying to give me medications. I'm like, no. If your blood pressure is not controlled and you're over 70, you are damaging your blood vessels, and the chances of you having a stroke is almost 1 out of 10. And I personally don't want those odds because I do like my brain. Now, stroke, again, can be in 2 different boxes. It can be the blood gets cut off to the brain, which is our ischemic stroke, and our hemorrhagic stroke. I came up with this. This is not, if you tell your doctor, oh, I'm worried about the terrible 10, they're going to be like, what are you talking about? Because I just made it up. But these account for 90% of strokes, okay? High blood pressure, smoking, an enlarged waist to hip ratio. That is a secondary metric for just having metabolic syndrome overall, but like all that increases body inflammation. Diet, physical inactivity, high cholesterol, diabetes, binge drinking can do it, heart disease, and like this protein, apolipoprotein B, which is kind of something specific. The hemorrhagic stroke, where you have a spontaneous bleed into the brain, high blood pressure, smoking, that metabolic syndrome, enlarged waist to hip ratio, and poor diet and binge drinking. So these are things that we can mostly sort of kind of try to control a little bit. These are what we consider modifiable risk factors. And the things that we have a little bit of control over accounts for 90% of all the strokes in the country or in the world, really. All right, last topic before we finish, and then we'll leave like 15 minutes for questions. Is anyone old enough to remember when the TV went off? Or is it just me? Okay, I see some smiles, yes. Like, okay. If you were up like me after like midnight and the TV went off, then you might have seen a sign that said, oh, do you have restless legs? Do you have restless leg syndrome? You might have PAD. And you were probably like, oh my Lord. I mean, I sat down for a long time. My toes are numb and tingling. What's wrong? So what is PAD? What is this thing that they were scaring us about at 2 a.m.? First off, let's just remind everybody the difference between an artery and a vein. I like to remember arteries as going away from the heart. So they provide food and oxygen for our organs. If your arteries don't work, the muscle and the organ dies. Just like we talked about today, the heart muscle, the brain, and the kidneys, like anything. The vein brings blood back towards the heart. And if the veins don't work, you have a lot of swelling. So like varicose veins and any other veins, that means the veins are incompetent, and they can cause swelling. But usually they don't cause anything to die. They just cause swelling. Now, why did I bring up that distinction? Because peripheral artery disease is specific to the arteries that provide blood away from the heart and give food to the legs. And so what is PAD? Basically, there's not enough blood going to the legs. People tell me, oh, doc, my legs are just tired after walking. Like I feel like I'm having muscle cramps all the time. Sometimes when it's really bad, they feel pain when they're sitting. They're like, yeah, my legs just hurt all the time. Like I'll sit down and my legs hurt. This is called restless leg syndrome. This is what they were trying to scare us about at 2 a.m., where like the legs hurt and you feel like a cramp. So you try to move to try to relieve that cramp. And I'll sometimes in clinic just watch patients with this particular severity, and they are just kicking their legs nonstop. So like they just kind of keep trying to move to get comfortable, and they can never really get comfortable. The reason that we talk about it is because wounds take a long time to heal, and you can have infections in the feet and legs, which can lead to amputations. And so one sobering reminder about what I've been trying to impart on everyone over the past 2 sessions is that arteries disease is through the whole body. So if your legs are hungry for oxygen, your heart probably is too, your brain probably is too. All these are connected. And so a sobering reminder is that one of our greatest Black American heroes, Mr. Jackie Robinson, actually died of a heart attack before he was supposed to get an amputation for peripheral artery disease. And so that's a sobering reminder for all of us that this is completely throughout our body. Again, risk factors. Some of these little things look familiar. The cholesterol causes plaque to build up in the legs. Diabetes can severely increase your risk of peripheral artery disease. I don't think I have had a patient with PAD. I think I have one who did not have diabetes, and I've treated a lot. I do like 4 or 5 arterial cases a day sometimes, but definitely 5 in a week. And almost every single one of my patients has really bad diabetes or had a history of bad diabetes that they later got under control. Smoking is independently linked to peripheral artery disease. Like really bad smoking, especially in young men, can cause the arteries basically to wither and they can lose toes. High blood pressure. Oh, I have the stroke thing again, but this also increases your risk of peripheral artery disease. But chronic kidney disease is another one. So kidney disease causes stress on the blood vessel, and it can severely increase your risk of peripheral artery disease. So why do I talk about this? Because this is one of those things, again, is all the stuff we've talked about where we have extreme health disparities in the Black community. They always like race and ethnicity, and if you live in a rural area, but there's so much structural bias and implicit racism that we even get to the level where we have these diseases, right? And we talk about the social determinants of health, chronic stress, not having health literacy, and health, like being educated and having health literacy are 2 different things, which is why it's so important that your organization is participating in this stuff, because as Black people, we don't have the same access to health knowledge because it's not volunteered for us. We have to go find it. It's not just lands in our lap. But lower access to high quality housing can sometimes be an impact and can increase our stress, and like our limited access to quality food and exercise. Like, it still burns me up that where I grew up, there weren't neighborhood parks, there weren't walkable areas. I mean, like, we had sidewalks sometimes, but we didn't always have sidewalks. So the evening strolls that you see these cute little families in Beverly Hills taking at 7 o'clock at night aren't a reality unless you want to walk in the middle of the street and risk getting run over. The health insurance, and then poor access to healthcare and treatment before it gets so bad. And then we say impact of health on jobs in the workplace. Let's talk about the impact of jobs in the workplace on our health. We talked about depression causing heart disease. We talked about depression and all these other problems causing all these systemic diseases. So we have all these, marks against us, but then we also, if we have diabetes and we smoke and we have chronic kidney disease, this can cause vascular disease and other things. And again, we put depression on here as one of those things that can increase the severity of these diseases. So how do we know if we have PAD other than these commercials? It's something very easy to test for, and it's called an ankle brachial index. Basically, they put a blood pressure cuff on your ankle, they put a blood pressure cuff on your arm, and then these numbers kind of give us an idea of what work we need to do. So what do I recommend to actually test and evaluate for this? Anybody who has diabetes should get an ABI at least once, okay? Yeah, if you have diabetes and no one's ever put a blood pressure cuff on your leg and your arm, ask your doctor, can you please can you please do an ABI, because it's a non-invasive test that takes 5 minutes, okay? It's very easy and it's very cheap, and most systems have no problem paying for these. All smokers should get screened at least once. And then anybody who has poorly controlled cholesterol, again, at least once. Like, ABIs and TBIs are so easy to do that we sometimes do them at health clinics. We were at Taste of Soul this past weekend. My group and some of the vascular surgeons were doing them there. So it's not something you need to, be in an uncomfortable position for a long time. The treatment is based on the risk factor. So we need to manage our risk factors. We can lower our A1C, treat our diabetes, lower our cholesterol, stop smoking. And then the medications are going to be blood thinning type of medications because the blood is not getting to the feet. So we need to open up the blood vessels. So we're going to take aspirin, Plavix, something called Xarelto is like the treatment recommended. And then Lipitor is often something that we recommend. But they're exercise programs. And so what I love for my patients is to do holistic care. So I'm not just going to say, oh, okay, take this medicine, I'll see you in 6 months. No. You're mine. You're going to go to this cardiac rehab program. You're going to do a graduated thing and a graduated walking program so you can regain some of the strength in the legs. And then you might need revascularization, which is what I love to do. It's minimally invasive. I just poke one artery, and then I try to open up all the blood vessels to give you the best chance of recovering. But cardiovascular rehabilitation is part of treating all of these illnesses. So every hospital really worth going to that has a heart program should have a heart cardiac rehabilitation, which means that they give you nutrition support, exercise program supervised with either a physician or a specialist in cardiac exercise, psychological support, because we know that, again, depression, anxiety make these diseases worse. They can cause these diseases, but they certainly don't help you recover from these diseases. And then medication, education, and monitoring are also part of these programs. So you don't have to be alone on this journey. If you have any of these issues or someone you love has any of these issues, you can have a team of people to support you. And with that, I want to say thank you. And I'm dedicating this talk to my granddaddy, who died of a heart attack when I was 16. And that changed the trajectory of my life. It's my granddaddy and my grandma, and that's my auntie. And changed the trajectory of my life and inspired me to become a physician. So even though he didn't live to see me become a physician, I hope that I'm making him proud. And with that, I will leave us for questions.
I did have a question about the ABI number. What should that index be?
Oh, That's an amazing question. Thank you for asking. Let me go back here. And so it should be 1 to 1.3. So if it's below 0.9, it's suggestive of peripheral artery disease. And so
Okay.
the breakdown, like how I like to think of an ABI is basically like the blood should be as effective going to my legs as it is going to my arms. If the blood is not as effective going to my legs as it is to my arms, something's wrong. Something might be lacking it.
Thank you.
Hello, I have a question. Oh, I'm sorry. Sorry, Tarina, you had your hand up. Sorry.
It's okay. Go ahead.
Okay. I was gonna ask if you have a history of familial hypercholesterol. I always get it tongue-tied.
Cholesterolemia?
Hypercholesterolemia, yes. Um, and you have to be, on meds and stuff like that. Are there any other things that you should be doing to kind of help the situation? Because it's not like just a regular, oh, eat right and work out. Like there's a genetic mutation that's involved. So what are some other things that you can do if you have that genetic marker?
That is an excellent question. And one of the things that I recommend is getting specialist care because, excitingly enough, a lot of drugs are coming to target specific things in these different cholesterolemia things. When I was in, during that cardiovascular research year, I actually was researching one of the causes. And now we are starting to develop new agents to actually treat the root cause as opposed to treating the symptom, which is essentially cholesterol. Basically, people with familial hypercholesterolemia have some kind of gene challenge where they don't process cholesterol and their body doesn't process cholesterol down during the normal pathways. And so like there's like things like TMPLA3 that we know about. And like I researched something called TM6SF2, which is very nerdy, but the specialist care is really important. Also, the diet is actually really important because we know that if you're not processing cholesterol, we need to definitely be very, very, very meticulous about our cholesterol intake. And so a lot of my, the folks that I've seen with FH typically try to do as close to Mediterranean and like, with a lot high vegetable, like more like kind of almost vegan diet. And they've seen, good results with like medication treatment, but definitely being able to go to a specialist that's up to date on the newer agents is going to be important. So I would recommend getting plugged in with, honestly, a cardiologist would probably be the best thing.
Thank you.
You're welcome.
I think I just wanted to share a story about how, important your veins and things are. So I had a hysterectomy a while ago, but prior to that, I was having problems with my knees. My knees were just hurting, and I had gone to get them checked to see if I had arthritis, and I was told maybe that was just early onset arthritis or something like that. And after my hysterectomy, and I mean immediately after, my knees didn't hurt anymore. And it was like the most bizarre thing. And I literally was not in pain. My knees did not hurt. So I asked my doctor, I'm like, hey, I noticed that I don't have any pain in my knees when I walk. And so she said that maybe the pressure from the fibroids was pushing up on a vein. And now that all of that, had been removed, that now it's been, I don't know, released, I guess, so to say. So the blood is flowing a little bit more freely through to the legs.
Yeah.
And even still to this day, 2 years later, I do not have that pain at all or anything in my knees. It was so strange.
Yes, it is strange conceptually, but anatomically, it unfortunately makes sense because basically our inferior vena cava and like the veins that go down to our legs, I'm kind of trying to draw it here, are in our pelvis. And so when someone has really enlarged uterus, like extremely, it can really push down on one of these things. And again, like my 405 analogy, these veins trying to bring blood back to the heart, and it is like, whoa, this is not going. And so it tries to find other ways to get around it, but that still can cause swelling down below of the obstruction. And so we do see that not uncommonly. And honestly, adding to my list of why pregnancy scares me, being pregnant can do the same thing physiologically. So the reason that women's legs swell when they're pregnant isn't just, oh, you drink, you're getting big because of the baby. Actually, the weight of the baby on the uterus is putting pressure on the inferior vena cava and basically slowing the blood flow from the legs back to the heart.
I feel so much better, and I don't even have like the swelling or anything in my legs that I had prior to that surgery. So, you know, just have to be more mindful about how all these things are so interconnected.
Yeah, thank you for sharing. And yes, it is shocking that our bodies they seem separate, but everything is so connected. Yes, can I reiterate the importance of seeing your primary care provider regularly during the childbearing years? Yes, yes, yes. So if you talk to anyone who's an obstetrician or OBGYN, I have some friends that are OBGYNs, and they are really funny because they're like, oh, like, we kind of are their primary care doctors, but we don't want to do the primary care because that's just not their training. They're trained to deliver babies, and a lot of some obstetrician gynecologists embrace their role as being kind of the primary point of contact and primary care for women of childbearing age. But having a primary physician who can look after the rest of you is extremely important, especially when we're talking about screening for conditions and getting a thorough family history, so that they know what screening tests to order and to be mindful of. That might not necessarily come up when you're having a conversation with an obstetrician gynecologist about, conception, delivery, pregnancy, family planning, or any of the other, things that are of their focus. So I encourage last time I talked about building your team, and your primary care physician should definitely be part of your team in addition to your OBGYN. All right. Any final questions? Oh, any additional reasons for restless leg syndrome? Yes, the restless leg syndrome is a big umbrella term for feeling like you need to move your legs. It can also be from sciatic nerve compression. So if you feel like a shooting pain down the back of your leg through the buttocks and down to the bottom of through the back of the leg, though, that could also be sciatica. Or you can have some if someone has a history of diabetes and they have some neuropathy, that also might cause some restless leg syndrome. So it's extremely non-specific, but classically people say that, on the commercials, they say restless leg and PAD in the same phrase. What's the best way to identify a doctor or a specialist? Oh, how do varicose veins come into play? Okay, so best way to identify a doctor or specialist, honestly, I ask a friend, and then ask a friend of a friend. But also ZocDoc is really good to find someone that matches your insurance. ZocDoc is one of that's the website. And then varicose veins come into play a little bit differently because veins aren't necessarily affected by the same issues as cardiovascular disease. Now, we do know that being women in and of itself increases our risk for having varicose veins. Part of that is because we have uteruses and we can get pregnant. So having venous stasis or having something inside basically can slow the blood flow. And then when the blood flow is slow in returning from our legs and coming back to our hearts, our body goes, you know what? I'm going to take this side street. I'm taking Sepulveda. I'm going to go up here and take some, you know what? I'm going to go up here and I'm going to, because the 405 is blocked, and I'm going to go other places. And these other places, they suspiciously look like varicose veins, don't they? They kind of become spidery and stuff. So varicose veins, basically, when the blood is slow in the big veins in the body, the little veins start sprouting up to try to take care of some of that flow, and then bypassing and going up to dump the blood somewhere else. Any more questions? All right. Well, I want to thank everyone for being so attentive and present for the presentation. It's always nice not to feel like I'm talking into an abyss. And thank you so much for your time and engagement today. And I just wanted to thank the health committee for putting this on, because this is so important, and just making sure that we know what to ask and how to advocate for ourselves as people.
And thank you, Dr. Gilyard. You make it easy to be interacting with your presentation. You're so engaging, you're so knowledgeable, your delivery, like you have this personality where it's a safe space. And that's what we wanted to create here with the health committee, is to provide safe spaces, particularly for our community, to come and get information that maybe we don't have access to. And then we can broadcast it out to other community members so that they can learn things. But the safe space is really important, especially as you've mentioned, in this current administration and the way our government is going. And now we're in this shutdown. So just anything that we can do to help the community. We are a Sisters Keeper, and we want to continue with more virtual health series like this. And again, I just want to thank you in particular for this topic. It was really, really great, very informative. We really loved having you.
Thank you. I've loved being here. So thanks so much. It was a pleasure.
Okay, so with that, everyone, thank you so much. We really appreciate your attendance. I'll give you back the gift of time. Hope everyone has a wonderful Thursday. Enjoy your weekend and get those checkups.
Yeah, please.